Okay, good evening, everybody, and dear Chairman, thank you very much. Thank you also, George Athanasopoulos, for kindly inviting me. It's a pleasure to be there. I am not sitting in a kayak, but this is Lapland. This is the north of Sweden, and it's very impressive. It's an ice age landscape. I am sitting in the proximity of Uppsala, which is about 1,000 kilometers further south. So we are going to talk about the role of cardiac imaging in the post-ischemia trial era. And let's look at ischemia. Why is this important? Ischemia was a large randomized trial involving 320 centers and about 6 years of recruitment. So relatively slow recruitment if you think about the number of centers and duration. And it recruited about 5,000 patients with proven moderate or severe ischemia who received an initial computed tomography to exclude left main disease or no CAD at all, and then were randomized to either the invasive approach, which would be coronary angiography and revascularization of ischemic territories, or presumably ischemic territories, or the non-invasive arm, which would mean conservative, optimal medical therapy, with, of course, the option of invasive treatment if needed, if persisting symptoms forced the doctor to switch over to invasive treatment. And in short, you see the results here. In terms of the composite outcome, which is sort of a composite of all the other outcomes in terms of death from cardiovascular causes or myocardial infarction, in terms of death from any cause, and also in terms of myocardial infarction. The invasive strategy and the conservative strategy showed no difference in outcomes. The cumulative incidence of all these adverse events was the same, irrespective of whether you chose the conservative or invasive strategy. Don't get confused by these insets here. The insets are the same as the whole picture. They are just a magnification of the y-axis to show the initial portion a little bit better. They show the two pictures, this one and this one, show the same thing, just on a different scale. So the outcome here, certainly somewhat surprising for the cardiologic community, was that there was no difference between between the outcomes according to the initially chosen strategies. And more specifically, if you look at some subgroups, quite surprisingly, for example, the degree of ischemia. So this was essentially moderate or severe ischemia. Even in the severe ischemia, there was no significant difference between the two arms. In the patients with 3-vessel disease, there was no significant difference. And even in the stenosis of the proximal LAD, which in the past has often been seen as something more or less equivalent to left main disease, there was no difference in outcome. So this was quite striking and against, let's say, at least old thinking, although in the past there were some studies, and I will just cite here the Courage trial that pointed into the same direction. This showed also in patients with stable ischemic disease that the long-term survival did not depend on whether you did PCI initially or whether you initially chose a conservative optimal medical treatment. So there was no effect on the long-term outcome here for about 12 years. So very, very respectable long-term outcome. So this is an important finding and a striking finding, which has consequences for how we treat patients. Another big trend which we experience in these decades, which is new compared to before 2000, is really that ischemia is becoming rare. You can see here data death rate per 100,000 in the United States. So these are for the whole United States data of death from heart disease, from cancer, and from stroke. And you will appreciate that, for example, there isn't really much optimism when you look at the cancer death rates, but the heart disease death rates go on a steep line, really practically linear line down. And this is confirmed also from other perspectives. So this is data from a big center that looked at their SPECT results over about 20 years in about 40,000 patients. And this is the rate of ischemia. The blue is the rate for ischemia and the red is the rate for abnormal SPECT overall. The percentage of all SPECTs that were done that showed ischemia, and you can see that this goes down from 30 to about 5%, so a dramatic reduction. So this is another important issue that impacts on how we manage our patients. And what are the possible explanations of this? Well, there are several things we can think about. We don't really know why this is so, but there has been a decrease in risk factors like smoking. There is some inexplicable decrease in CAD as such, a little bit like rheumatic heart disease. You can explain it by the antibiotics, but there must be some underlying extra factor that decreases the incidence of this disease. There is, of course, better medication, and there is also better invasive treatment, and maybe that today we are earlier in starting the therapy. But it is a very massive trend which changes the whole of cardiology. So where does that leave us with our beautiful stress tests, stress imaging? Here you have a positive stress echo, obviously, images at rest and under stress, and you can see that a big apical akinesia, dyskinesia has emerged with stress, and we all have done many such tests, and this used to be really a substantial portion of what a cardiologist does. Where do we go with all of this? Is this all now over? Well, let's look a little bit further and see where we stand now with stress testing. This is the lesion that underlies this apical dyskinesia. So we have a clear, very tight proximal LAD stenosis. And let me step back for a moment. It is really remarkable when you have spent, like me, maybe like 30 years in doing non-invasive imaging, and a large part of this is testing for coronary artery disease. And I've also been like 25 years in the cath lab, not anymore, and have been hunting their stenoses. And we thought always that missing a stenosis is about the worst thing that a cardiologist could do. And now it turns out that this is actually not entirely true, and that the real factors of survival for the patient are not single stenosis. So where are we going with all of this? I think we are facing a paradigm shift for cardiac imaging in coronary artery disease. We used to concentrate on identifying ischemia or coronary artery stenosis as cause of symptoms and impaired prognosis. And we actually thought that ischemia sort of determines prognosis. And now we see that things are somewhat different. We are now starting to identify atherosclerosis, which you can define as plaque burden, as the most important prognostical factor and not ischemia. The atherosclerosis is what may kill the patient and not necessarily ischemia, except for some cases of overwhelming ischemia like left main disease, but certainly not moderate ischemia. And we recognize that plaque rupture or infarction may occur in places where there were non-obstructive plaques, so places we cannot identify by ischemia imaging. And also plaque erosion. This is a new mechanism that we recognize now that is also which also leads to infarction. This may also occur in non-obstructive plaques. So these are atherosclerotic lesions which we cannot hope to identify by looking for ischemia. And in an era of decreasing significant coronary artery disease, the aim, the goal of improving prognosis becomes dominant over just detecting and treating ischemia. So we are more and more moving from treating symptoms to improving prognosis. Of course, we still want to treat symptoms, but symptoms have become rarer, and now the task is more improving prognosis, and this leads to a big shift in the direction of morphologic diagnosis, and this is CT based diagnosis of atherosclerosis, which is becoming increasingly important. Let's look at some data for these statements, supporting these statements. So, for example, here you have a statistic of 2,600 patients who had coronary artery disease, but no obstructive lesion, no lesion over 50%. And what it shows is the importance of non-obstructive plaque, of plaque burden. If there was no coronary artery disease at all, the survival probability, as you would expect, was extremely high. It's like 99%. If there was some plaque, it was distinctly worse. And you could also see that the number of involved segments, so it's not only whether there is or is not some coronary artery disease, but also the amount has a direct relation to the mortality risk. So down here is the number of involved segments, and you see how this increases the mortality risk. So presence and extent of plaque and, of course, therapy determine the prognosis. Less so ischemia. None of all these plaques was causing ischemia. Another issue is that we understand more and more that not all plaques are created equal, and that there are features of plaque that are important for prognosis and that can be identified actually non-invasively. Here you have the classical idea of the causation of myocardial infarction by a ruptured atheromatous plaque, which catastrophically creates an occlusive thrombus, and that is certainly continues to be true. However, this does not necessarily imply a very big plaque. It usually implies some amount of plaque, but this does not have to be 90% stenosis. This can be 50% stenosis. This can even be less than 50% stenosis. And on the other hand, we recognize more and more that there are other forms of myocardial infarction, and that is plaque erosion, for example. So in these cases, there isn't a catastrophic rupture, but there is sort of a slow erosion of the endothelium, and there may be non-occlusive thrombus, and there may be peripheral embolization, and there may also be complete occlusion, but here the pathophysiology is somewhat different from the classic plaque rupture, and also the morphology of the plaque is somewhat different from this situation with a thin fibrous cap and a large lipid pool. So these plaques are somewhat different from the classic plaques we know that cause myocardial infarction. Here are some optical coherence tomography pictures. You have down here the classic plaque rupture with a big hole in the wall. This is where the lipid pool essentially came into contact with blood, and now this pool has been evacuated into the vessel, and this caused myocardial infarction. And you can see some thrombus over here. But there's also, as I said, the plaque erosion situation where you don't have this big lipid pool, you don't have the thin fibrous cap, and you still can have some thrombus here because of denudation of the epithelium. And you can see here a graphic that sort of symbolizes this. So here there is no sudden rupture and explosion of some core to the lumen, but instead there is an erosion of the epithelium, and there may be a slow build up and occasionally also embolization of a platelet-rich white thrombus. And these things can be seen to some degree, at least on CT. So there are high-risk plaque features, and these are, for example, positive remodeling of plaque, meaning that the vessel size becomes bigger without necessarily encroaching on the lumen, so it sort of expands on its outer circumference. There is low attenuation plaque, there is spotty calcification, and there is the so-called napkin ring sign, which is also essentially a soft core of a plaque that you can see and measure. You can measure the Hounsfield unit, so this can be expressed in numbers, whether there is low attenuation or not. And having such high-risk features makes a difference. So you see here data from patients from the PROMISE trial, we'll get back to that, who all had low-grade stenosis, so nothing that causes ischemia. And if you separate them by those who had more high-risk criteria, that's the red curve, and those who had less high-risk criteria, you can see a considerable difference between the incidence of bad things that happen to them. So death and myocardial infarction and unstable angina, much more likely in those who have high risk criteria on their plaques, which all are nevertheless low grade. So we appreciate here that we are able to non-invasively characterize those plaques and to gain information about prognosis here. A footnote or a remark, this what I've been talking about, characterization of plaque and recognition of plaque, presupposes that you don't do only coronary calcification imaging. So not only the calcium score is, of course, also a parameter of atherosclerosis, but it gives an incomplete picture of coronary atherosclerosis. And very recently, an enormous trial here in Sweden was published where a population sample of people, so not patients, people who had no disease, no history of cardiac disease, underwent voluntary CT over 25,000 subjects, Swedish subjects, over 50 years and under 65 years. And this showed, as you would expect, a large number of atheroma, etc., and some coronary artery disease. But importantly, it also showed that even if you don't have calcification, you have an incidence of 5% atheroma and of 0.4% significant stenosis. 0.4% does not sound like a lot, but this is population based. So this means that the coronary artery calcification is a very imperfect tool and probably not the best to evaluate prognosis. So these findings from many such studies lead to current recommendations how to image the chronic coronary syndromes, and in a general manner, you can say there is a continuum from computed tomography to ischemia testing to invasive angiography, and essentially the lower the likelihood and the more your aim is to exclude coronary artery disease, the more you have to go to morphology and you have to use coronary CT and best coronary CT with angiography, because that allows you to see plaques and to even characterize them. The more your goal is really treating symptoms, the more you go for ischemia, and if you have a very high pretest likelihood, you can skip that part and go directly to invasive angiography with the intention to treat in the same session. So this is a result of the emerging, or these recommendations essentially are the result of the emerging role of morphologic imaging. And if you apply that, and this is what was more or less done in the PROMISE trial, where about 10,000 patients were randomized, patients with stable chest pain, with chronic symptoms that were randomized either to anatomical testing or to functional testing. So CT versus one of the classic ischemia tests, stress echo and SPECT essentially. And about 10,000 patients were randomized, and you can see here the percentage of patients with adverse events. Again, this is just a magnification of this scale here. Essentially no difference between anatomical testing and functional testing. So both are, at least in the short term, equivalent. These are months here. However, in the long term, of course, there is a advantage for anatomical or for visualizing morphology, because you get information about the long-term prognosis. And in fact, it was found that that imaging by computed tomographic angiography is better in excluding long-term events. So if you have a negative CTA, your event rate, 3-year coronary artery disease event rate was 0.9. If you had a negative stress test, your negative event rate was still very low, 2.1 over 3 years. So that's lower than 1% per year, but it is more than double as high as for a negative computed tomography with angiography. And of course, because many patients have these results, are negative, this difference, in fact, if you apply it to a large population, is a very important one. So the sort of negative predictive value of CT is much higher than the one of stress testing. A few words about acute chest pain. Up to now, we have talked about chronic chest pain, stable patients. How is this with the patient showing up in the emergency room? This is a picture from the latest AHA-ACC chest pain guidelines, which just came out. And here you see the top 10 causes of chest pain in the emergency department based on age. And there are several messages here. One message is the blue bars. The blue bars is non-specific chest pain. And you can see that this is the absolutely dominant cause for chest pain. So it is important to have some kind of test to differentiate non-specific chest pain from all these specific causes that need to be treated. The other message is that in patients under 45 years, coronary artery disease doesn't even show up in the top 10 causes. So it's a rare cause of chest pain. However, when people get older, then this bar here, the brown bar, this is coronary artery disease or coronary atherosclerosis, becomes bigger and bigger, but it's still sort of quite small compared to the blue bar, and that means that, of course, we need some tests to identify coronary artery disease. And what should we use? Well, again, if you have acute chest pain and an intermediate risk, that means that there is no troponin and not an overwhelming risk factors. And if there is no prior testing, so that's the sort of standard situation, then you have two possibilities. You can go to stress testing, like exercise, ECG, stress echo, and SPECT, but now also stress CMR and stress PET, and actually also perfusion CT. So the list continues to become longer. You can go to stress testing, but you can also go to coronary computed tomography with angiography. So this is the situation from PROMISE. The two have equipoise. The outcomes are essentially equivalent between the two strategies, with a certain advantage for the very long time prognosis, about which we don't care that much in the acute situation. So in summary, I think we need to adapt to this situation after the ischemia trial in the light of decreasing incidence of acute ischemia, also in the light of overall decreasing coronary artery disease, especially severe coronary artery disease. So I think we can conceptually think about it in the following way. If we focus on symptoms, and real typical symptoms of coronary artery disease are relatively rare, at least in those populations that I have seen, possibly in other parts of the world. They are more frequent, but really classic angina, like out of the Netter Atlas. This is not so typical, or this is not so frequent. If we really have symptoms, then it is reasonable to identify inducible ischemia in the first place, and that would be a case for stress testing. So you want essentially to identify what causes the symptoms, because then you know how you can cure the symptoms. Of course, also CTA is able to identify ischemia. There is now the non-invasive FFR, which is not perfectly validated, but seems to sort of work. And there is also perfusion CTA, which is coming. So similar to, for example, stress CMR, there will be the possibility to look directly at perfusion from wash-in and wash-out curves on coronary computed tomography angiography. And this whole procedure, primarily by classic stress testing, is the gatekeeper for revascularization. So this is as long as you focus on symptoms. As long as you focus on prognosis, however, and that is going to be more and more our goal as cardiologists, what you want to know is certainly also ischemia, especially whether there is overwhelming ischemia. But in the largest group of patients, you want to know, is there atherosclerosis present, and what is the extent? And are there high-risk features of atherosclerosis, like these signs that I showed you? And that is in a crude way possible by calcium imaging, but considerably better by computed tomography with angiography. Of course, presence and extent of inducible ischemia is still also a prognostic factor. If you have a negative stress test, this still carries a real good peak stress test that shows no ischemia at all. This carries a very good short to medium range prognosis, like I showed you in the data from PROMISE. However, the negative predictive value is not as good as with a negative CTA. So keep in mind, testing for ischemia does not provide information about the extent of atherosclerosis, and the absence of an atherosclerotic risk is best determined by a negative computed tomography with angiography. Thank you very much for your attention, and I look forward to some discussion.
Thank you, Professor Flachskampf. So I can introduce my co-chair, Dr. Agathaggelou from Cyprus. So, Dr. Agathaggelou, do you have a comment on this very interesting talk?
Thanks for the opportunity, Mr. Chair. I would like, from my behalf, also taking the opportunity to express my sincere appreciation for this honor and invitation to participate in such an exclusive seminar. Congratulations on Mr. Flachskampf. I think now we get more non-invasive in our diagnostics, especially in patients that they have a stable coronary artery disease, that they occasionally they develop a chronic angina, and sometimes in the perception of the cardiologists and patients' symptoms, especially if they keep on complaining of angina, we all have the tendency, in the absence of any particular high sensitivity test of establishing vulnerable plaques, that will be probably the cause of the pains. We have the tendency of referring the patients for coronary angiography, and after the ischemia trial, of course, our practice and the way we tackle down the chronic angina, it's a bit different nowadays. After questioning whether patients with moderate to severe moderate atherosclerosis, non-obstructive coronary artery disease might be managed non-invasively. My question is, in case you have a CT with the calcium score of more than 150, 180, and they have a diffuse atherosclerotic changes with some plaque remodeling, but not evidence of overt obstruction on the CT. And despite of that, the patients complain of exertional chest pains. How would you tackle the whole problem, especially if the patient develops an acute coronary syndrome with non-ST elevation of my positive troponin, after reassuring him before that there is no obstruction nowadays, and now he comes up with some occlusion problem?
Well, if I understand you correctly, we are talking about a patient who has coronary artery disease diffusely and then develops an acute coronary syndrome. Is that correct?
Yes, he has a chest pain, chronic angina. We managed for a couple of months with some medication, tried to relieve the symptoms, but nevertheless, after 6 months, he comes with plaque rupture. He develops acute coronary syndrome with positive troponin, non-ST elevation, and the patient claims that you reassure me that this is non-obstructive coronary artery disease with the symptoms we can live on, and we try to manage it with medication.
Well, first of all, if there is an acute coronary syndrome, the patient needs an invasive coronary angiography. There's no question about that, especially since let's say there are data showing that what was non-obstructive can become obstructive very quickly, and probably these plaques grow very quickly in the days before they finally rupture. So something that has been 30% may suddenly be 80%, and therefore the argument that it's non-obstructive is not true anymore. And so if you really have coronary artery, if you really have an acute coronary syndrome, then these patients need an invasive coronary angiography and need a stent and need all this treatment. Now, you say that the patient will be disappointed that he or she has been told that everything is okay, and nowadays we treat these problems conservatively, and now suddenly after conservative treatment the patient ends up in the hospital in the emergency department. The thing is, of course, we still cannot identify which plaque will lead to to a catastrophic event. So there is no alternative than to treat it as long as symptoms are stable and there is no acute ischemia. You need to treat medically, because you could treat 5 different non-obstructive plaques, and the 6th and the 7th may give you symptoms in the next 4 weeks. So there is no way to identify or you can see it in another way. There are many more plaques than those that will lead to an acute coronary syndrome. So there's no way you could prophylactically treat all of them, or do a bypass operation prophylactically. That would be completely useless. So I think still the strategy is right, as long as symptoms are stable, and you don't have you have no localized inducible ischemia to treat conservatively. There's no other option. But if once the troponin goes up, you need to do an invasive angiography, because this is a fluid situation. A very good cardiologist, Hugo Katus in Germany, once said, there is no such thing as stable coronary artery disease, and that's true. This is in constant flux, and the plaque that yesterday was 40% can be 80% tomorrow.
Yeah, but if I may add to your comment, Professor Flachskampf, in order to identify, for the time being at least, these vulnerable plaques, you need to do invasive imaging, like virtual histology, like in the prospect study, which showed that the TICFAs, or the large plaque burden plaques, are the ones that they're going to rupture. So we identify even significant ischemia in the stress test, and then based on the ischemia results, we are not supposed to do anything on that, right? Because we're not saving any lives, apart from maybe if you do the complete revascularization. So I would like to ask you, how do you tackle this thing? And also another question, maybe what's your take on this, the last exploratory sub-study of the ischemia presented at the ACC this year, which showed that the completeness in revascularization actually has a role in improving the mortality rates in these patients, in these stable patients?
Well, several answers. One thing is we actually do not need necessarily invasive imaging to identify high-risk plaque features. I tried to show this. So there are some features like plaque remodeling, like the Nepkin sign, like spotty calcification, that can be identified on CT, and that show that these are dangerous plaques. However, that does not have an immediate practical consequence. It just shows you that there is coronary artery disease and it needs to be treated in an optimal way. But this does not necessarily mean this does not mean that you need to put a stent there. And then again, I mean, if ischemia doesn't say you should never treat a patient invasively. That is not the point. And in the conservative arm of ischemia, I think like 30% or so switched over to the invasive arm. So if the patients have continuing symptoms, of course it is meaningful to and correct to go to invasive diagnosis and treatment. But at least in my experience, we have been treating an awful lot of patients who had no real classic anginal symptoms, patients who sort of felt fatigued or who developed, atrial fibrillation, or who didn't feel well, things like that. When we saw in such a patient a coronary stenosis, we thought we need to treat this, because otherwise the patient will die sooner or later. And this logic, I think, has been removed by ischemia.
So good. Any other comment, George? So,
Okay, Frank, thank you very much for the very elegant presentation. You integrated the data from the literature and for the ischemia trial itself in a very clinical orientation. I think that you stated pretty clearly that when you have a non-typical chest pain, in a patient with no known CAD, the CT information about the calcium deposits and the anatomy does provide an excellent outcome, and it is true. In contrast, in the patient with known CAD, even with atypical chest pain, I think that we have to be more aggressive using stress tests, especially stress tests under treatment, in order to justify the presence of inducible ischemia. And also I would like to add our personal experience during the last 20 years, combining the information of the stress echo data with the distal LAD flow reserve. Once we find an excellent number for CFR, more than 3, apart from the safety that the left main to distal LAD tree is free of obstruction, we also have some informative data about the microvasculature. So these numbers, if we may incorporate them properly, we might have a much more safe net for the negative predictive value of stress outcome. And also, just a reminder, you know it, that in the PROMISE trial, the key stress test which was used was by 70%, 75% SPECT scintigraphy, not stress echo.
Yeah, this is certainly correct. I mean, the issue of perfusion anomalies that are not caused by epicardial stenosis. So the whole issue of microvascular disease is something that CT does not address. There is some role here for sort of big machine imaging in terms of course, PET and also CMR perfusion, and perhaps in the future there will also be a CT perfusion that might be able to diagnose microvascular disease. But this is done very nicely if you can do it. Can be done by echo. I agree. This is a facet of coronary artery disease which is not covered by CT. Absolutely, I agree with that.
So good. Thank you for clarifying these questions. So if Dr. Agathaggelou doesn't have any other query, Dr. Agathaggelou? So we are fine.
Sincere thanks to Professor Athanasopoulos for the kind invitation, and I thank you, co-chair, and I congratulate Professor Frank for this elegant presentation and very enlightening and very, very challenging, I would say, on clinical practice.
Thank you very much.
Thank you.
Thank you.
Thank you. So this session is